All right, this is going to be a fun chapter. This is going to be a little different. We're going to be clinicians together and go through some visual diagnoses and talk through, really the point of this is to talk through the reasoning of how you get to a diagnosis. So this is a little bit of a game. What I would encourage you to do is to just think through it slowly with me. We're going to walk through each step of these cases together, talk about why we would do something or why we wouldn't do something. I really would prefer this to be interactive, but doing this, the camera, recording this makes it a little more difficult. Typically, I like to walk around, and so I'm up here, so you got to work with me and try to give me a little bit of something when I ask some questions. And I would encourage you not to cheat. Don't look ahead in the chapter. We actually have all the answers at the end, so you don't need to take any notes. They're all there for you. But for the purpose of actually learning something, try not to look at them now because it kind of takes away the fun of it. These are kind of hard cases, I think, some of them. They're not all emergencies, but they're certainly presentations we see. So we want to highlight some of the zebra things that you might find out there with some of these presentations and talk through sort of how you might have gotten there as the detectives that you are. So the first case, all right, we got a 49-year-old male for you. He's coming in with a chief complaint of right upper quadrant pain. All right, so start thinking, bring down your menu of right upper quadrant pain. What am I thinking? It's been there for the past 2 months. When you ask him how long, 2 months it's been there. It's pressure-like in terms of what it feels like. Feels pressure-like. It's pretty much constant. It's there all the time. It's not radiating. He has no exacerbating or alleviating features. You ask about past medical history. He says, yes, I have hypertension. I'm not taking any meds. He works on a ranch, so you've obviously gotten to some detailed questions. Probably not everyone would get that on the first round of questioning, but it turns out, okay, let's say he's got a big belt buckle, and you're like, where do you work? And he's like, I work on a ranch. All right. He's got a remote history of heavy alcohol use, but he's not currently drinking or smoking or using any drugs, but says, I used to be a big drinker, doc, but I quit. All right, review of systems is negative for fevers, respiratory or urinary symptoms, no vomiting, bowel movements are fine, no melena, no bright red blood per rectum, all that sounds fine. It's just this pain. It's just nagging all the time, just having this pain. I just got to know what it is. Vital signs, fine, unremarkable. He looks good. Doesn't look sick. When you push around up there, he's got some tenderness in that right upper quadrant. Yeah, that's kind of bothering him. But it's negative Murphy's sign. You can feel the liver edge is palpable. And otherwise, the exam looks fine. So you're just left with this guy with right upper quadrant pain, been going on for a couple months. And we see a lot of right upper quadrant pain. So tell me a little bit about, when you think through differential, there's obviously the things that you think of. What's the most common thing this could be? What's the most dangerous thing that this could be? You know, we always kind of play that game in our mind. So what do you, in terms of all the things that you see with right upper quadrant pain, what are the things you're thinking this guy might have? Anybody? Gallstones? We see a lot of biliary disease. Could this just be gallstones that's cooking along for a while? Now, what goes against it? Why is it maybe not gallstones? It's been 2 months. It's not really colicky. It's not really coming and going. You know, diseases don't read the textbook, so it's certainly possible this is still just gallstones that, you know, has been cooking around for a couple months. What do you think the most serious thing it could be? Like, what's the most dangerous or most serious thing it could be? Could be liver cancer, right? Guy says he's a remote alcohol user. He drank for a long time. Could he be presenting with liver cancer, that this is what he's walking through the door with? I totally agree. Could be liver cancer. Are you going to send labs on him? He looks good. It's been 2 months. Are you going to do a workup? Yes. Probably yes. Here's a guy. This sounds like the kind of guy that doesn't come in a lot, right? He's not the kind of guy who's coming in all the time. So something's bothering him about this pain, right? Sometimes you have to take that patient, you have to say, is this the kind of person that just is stoic and wouldn't be here unless there was really something wrong? This sounds like that kind of person. So I'm gonna do a little bit more. What's the weirdest thing it might be? It could be something weird. It could be some zoonotic, you know, something really odd. That's a possibility. Maybe you want to ask some more questions. What else might you want to know from him? So what kind of animals does he work with? Any kind of pork that he eats? Is there any kind of unusual things to this that might get me down a path of something odd? He tells you that he works on a sheep ranch. Huh, all right, fine. That's interesting. You know, here's a guy also, you know, to think about where could I fall into a cognitive bias with this person? He's given me this history of alcoholism. Maybe I'm anchoring on that too much. Maybe this is somebody who, because of the ranching, I'm just thinking about the zoonotic things or odd things and not thinking about the common things. So try to also check yourself as to where could I go wrong with this case. All right, so he's a rancher, doesn't come to the hospital, but I'm going to take him seriously because I think that he's probably here for a reason. So labs that you're going to send, I think this is pretty straightforward. Most people would send a CBC, a chem panel, probably LFTs, it's right upper quadrant pain, maybe a lipase, maybe you send a UA. I probably wouldn't send a whole much more than that, but I'm probably, if I have a bedside ultrasound, I'm going to wheel it over and take a look. And in terms of imaging, let's say you don't have a bedside ultrasound or you don't do ultrasounds yourself, would you order an ultrasound or would you order a CT scan? And maybe that depends on what time of day it is and what your resources are, but probably if you're really focusing on liver, ultrasound is better at liver by itself. CT scan is better at giving you pictures of things around the liver. So whatever you have available to you, but ultrasound's probably the test of choice. And all of the labs come back while you're waiting for your imaging, and they're all normal. Your CBC is normal, your LFTs are normal, everything looks normal. That's reassuring in terms of it being an acute infectious process. That's good news, but I still think something's wrong. All right, so we get the ultrasound here, and I have a picture for you, the ultrasound here, right? The gallbladder looks normal. The bile duct looks normal, but you see this thing. There's this thing in there. How would you describe this structure that you see? Septated, yes. Cystic looking, right? Looks odd. You definitely see septated, cystic, something in there. What is the differential for this thing? What could it be? It could be something like cysticercosis. It could be something like, could this be an abscess? Maybe, although there's a lot of different, usually in abscesses we see kind of one fluid-filled sort of structure, but it could look lots of different ways. So maybe this is an abscess. Could this be metastatic disease? It doesn't really look like Mets, and I only see one thing. I don't see a bunch of things. Usually when you have Mets to the liver, you often see multiple lesions. Could this be polycystic liver disease, genetic condition that's related to polycystic kidney disease? Could be polycystic liver disease as a possibility. All right, so you see this septated thing. You've got this rancher. You're like, I don't know what this is. So you're going to go to Google, and you're going to put in sheep rancher and cystic liver thing, and you're going to come up with something. Because I wouldn't know what it was right away. And so we've got the differential. We've got benign liver cyst, polycystic liver disease, could be some kind of abscess. This is probably a echinococcus. This is what this is. This is a cystic thing. You probably, somewhere in school at some point, you learned about echinococcus, and maybe you haven't opened that file for a while, but let me open it for you. Echinococcus is a parasite. It's a tapeworm. It lives, its definitive host is in carnivorous animals, so like dogs, coyotes, things that eat meat, eat things like sheep. That's the definitive host. They poop out the eggs, then things like sheep and grazing animals eat those eggs, and then they poop out eggs, and how do we get it? We get it by eating things contaminated with feces that have eggs in them, and so we get it that way. But its definitive host is these carnivorous things. And it used to be that the carnivorous, dogs, coyotes, wolves, they don't eat us. So we're not a host that passes it on, but we are a host that can be infected. These tapeworms can get into your gut, basically, and they can start to make these cysts as they poop out their eggs and their larvae in your system. And these cysts can be anywhere. They can go to the liver. They can also be in the lung. They can basically go into any organ. And they just grow there and don't really cause much in the way of symptoms until they get big enough to cause a mechanical issue. So in this case, this cyst has gotten so big that it's pushing, which is why it's been constant pain for 2 months. So this is an echinococcal cyst. And those are called hydatid cysts. Remember that? Hydatid cyst? That's what this is. This is a hydatid cyst. So this is a tapeworm, echinococcus, goes between these carnivorous hosts and herbivorous hosts like cows and sheep and goats, and we get them by inadvertently ingesting fecal material that contains tapeworm eggs, which is always really gross to think about, but it happens. And maybe your dog was playing with the sheep and you're kissing the dog's face, and that's how you get that. So these cysts are very resistant. They survive freezing. They can really hang around for a long time. So once these cysts get into the body, they basically start growing. Some people, if they have it in a lung, for example, can start coughing up pieces of these cysts if it starts to rupture inside the lung. This patient has it in their liver. So they're silent for a long, long time. Most patients, like 80% of them, have only one organ involved. So it's not usually planting all over the place. It's usually in one place. And they can rupture. And if they rupture, they can cause peritonitis or hypersensitivity reactions because of the stuff that's inside of them. So this isn't something that makes you super sick in general. You're usually, it's pretty silent until it presses on something. And this could have been a presentation of acute right upper quadrant pain and peritonitis because of a rupture. That's a possibility too. So what would you do after you make this diagnosis? Well, you'd probably consult your your infectious disease partners, because this isn't something that you see very often. Most of the time, these cysts actually have to be surgically removed because they're so big and mechanically a problem, and they don't go away so easily with parasitic drugs. But most people probably would put them on an anti-parasitic drug. Most commonly, that would be like albendazole, something like that. There's no actual test that you can send to diagnose this definitively. There's no like rapid antibody that you're going to get back, anything like that. But you might want to go back. When you think of parasites, there are clues sometimes on labs. And probably the most common one that we overlook a lot is the CBC and the differential, right? Looking at the eosinophils. That's a place to go back and look. And when you see bumps in eosinophils, there is a little mnemonic to help you remember the differential diagnosis of what causes eosinophilia. And that is NAACP. That is the mnemonic that I remember for eosinophilia. And it stands for neoplasms can do it, allergies can do it. What's the other one? I wrote it down. Addison's disease can do it. That's the one I never remember. Collagen vascular diseases can do it, and parasites. So that's the differential when you see a little bump in eosinophils, to think about this. Is it something like a collagen vascular disease? Is it a parasite? Is it an allergy? Addison's disease is the one I always forget. Neoplasm, some neoplasms can do it. So that's a little clue that we often kind of just scan past those eosinophils and don't look at it. But when you see a bump, think about it. And so you've got this thing, you've got this nasty cyst in there, and so they can drain these sometimes or just pull them out, and often they'll start anti-parasitic drugs. Cool. Kind of gross, but kind of cool, right? I mean, can you imagine if you have your ultrasound and you saw that thing, you'd be like, what is that? This septated thing, I gotta figure it out. All right, so that's echinococcus. Let's move on to another one, not quite as exciting, but nevertheless common. We got a 65-year-old man, comes in with a lesion on his hand, lesion on the hand. It's been present for months. This is one of those cases where you're like, this has been there for months. Why today? Why now? But at some point, everyone comes in. That's okay. We never blame patients for these kinds of things. At some point, something worried them, and part of our job is to get to what worried you about it today. What changed? What is it about it today that brought you in? And sometimes it's a family member. My daughter saw it and really wanted me to come in and get it checked out. So I always like to kind of find out what motivated you to come. This is not painful, and here, the daughter expressed concern. He says it doesn't hurt. There's no real tenderness there. You go through, have you been losing weight? Any systemic stuff? Really nothing. No fever, nothing like that. Sometimes it bleeds. He says, sometimes I knock it against the thing and, it bleeds a little bit. All right, so do I need much more information? I don't know that I need a ton more information. When you talk about derm stuff, anything that's derm, there are some things to walk through. Derm does require a good history to talk about any new topical stuff you've been putting it on. Are you on any new medications that could be causing this rash or this derm presentation? Any other comorbidities? There's lots of derm findings associated with systemic illnesses. So you do have to do some digging, even though you're kind of isolated to this one thing. What do you do for a living? This patient says, oh yeah, I'm a truck driver, and I'm on the freeway, I'm on the road all the time. Okay, we'll see if that plays into it at all. So you see this thing. So what do you think? How would you describe this lesion in your chart? What are the words that you might use? What color is it? Looks sort of pinkish. I mean, we have a color printer here. It looks pinkish. How else would you describe it? It's raised, yes. It's raised. It's maybe kind of pearly, perhaps. That's a word that, kind of these derm words that you kind of remember. Pearly is something they like to call it. So maybe pink, a little raised, pearly. It's non-painful when you touch it. And if you really want to mess with it, you could get it to bleed a little bit. right? If you really want to mess with it. Not that we would, but you could tell that it looks like a little bit friable, maybe, right? Okay, so if you're going to call a consultant, let's say in this case, and sometimes we wouldn't, this is an emergency to call a dermatologist over, but let's say, like in my system, this is crazy, you'll think this is crazy, but I work in a county place where I can't get specialty appointments for people. So if we want to get a relatively, urgent, meaning that not 6 months away dermatology appointment, we have to call the dermatologist to get approval for that urgent appointment, because it's a very limited resource. So if I called the dermatologist to describe this, I would first say, I don't need you to come in right now. Every time you call a consultant, put their mind at ease that I'm not calling you to come in right now. They're like, yeah, great. Now I'm happy to talk to you. All right, I'm not calling you to come in, but I've got this patient, blah, blah, blah. It's pearly, it's raised, that's how I would describe it. If I rub it, it bleeds a little bit. So what do you think that this could be? What's the most serious thing it could be? Cancer, right? Skin cancers are pretty common. Here's a guy who's a truck driver, maybe his hand's out the window, maybe he's getting a lot of sun exposure, could be something like that. Of the cancers, what's the most common thing it could be? Basal cell. Basal cell is the more common. Could be squamous cell. I can't tell. I don't have a pathologic slide at this point, but basal cell is more common than squamous cell. So basal cell is kind of up there. What about something that's not as dangerous, but is just common? Bumps on the hand. Bumps that look pearly and raised on the hand. Like a ganglion cyst, exactly. That's probably one of the more common things. Although this is a little bit of an odd location, and certainly ganglion cysts don't bleed if you touch them, right? They're not friable, they don't look kind of angry, but it could be an unusual ganglion cyst. It could be something like an epidermal cyst of some kind, so it could be benign. I'm not completely convinced, but this does sound a little bit on the cancerous side. All right, could it be something like a sporotrichosis? Maybe he's a gardener and he's got some lesion there from something like that. Maybe that's something like that too. Remember also, in terms of basal cells, you can get basal cells anywhere, including your eyes. So if you see something that's like a stye or chalazion, one of these bumps on the eyelid that's been there for a long time, not going away, maybe it bleeds a little bit, don't forget about basal cells in that area as well. So skin cancers can be in any kind of unusual places, so we want to keep our mind open to those kind of things and not blow off things like that are not going away. It probably needs a biopsy. So this is basal cell carcinoma, most common form of skin cancer. These tend to occur in sun-exposed areas. They can be on lid margins. They tend to be pretty slow growing. The good news is they don't really metastasize that fast, so it's a very low potential for that, and they're going to need to be excised, right? So this person needs a biopsy and then an excision of this thing. So you need some prompt outpatient evaluation. Hopefully we can get him in to see somebody. All right, our third case, which is I think our last case of this section, we have, oh boy, another derm case. Not my favorite. Many of you probably feel the same way. Derm is not my favorite area. I mean, you do a derm residency for a reason. I lived with when I was a fourth year resident, my roommate was a derm resident across town at UCLA. And he was studying all the time. I mean, he had books, big books. He was learning so much stuff. I remember talking to him about the stuff he was learning. It was not part of my curriculum in emergency medicine at all. He had so much specialized knowledge. And he would go to these half-day clinics for like derm patients who are between this age and that age with HIV and other comorbidities. They have these very specialized clinics to look at derm. I mean, if you're really training, there's a lot to know there. He also took a lot more naps than I did, I'll say that. His life was pretty good. But we got a 50-year-old male. He comes in, rash on the legs. It's been there for 3 days, so relatively acute. The rash is itchy but not painful. He's not had any fevers, no other systemic symptoms. So you got to dig in a little bit. Now I got to ask, got to get some questions. Tell me about your past medical history. He's got hypertension. He takes a water pill. Doesn't know the name of it, of course. He has a remote history of IVDU, but he quit 15 years ago. Not recently, doc. Nope. He denies any new medications. He doesn't know detergents, no lotions. You're walking through all that. He's like, no. I use my regular stuff. So there's a lot that this could be, right? This is, to me, I'm like looking at this rash. To me, I'm interested in this rash. I once learned in terms of rashes, if you know what it is, why touch it? And if you don't know what it is, don't touch it. So in either case, you want to be careful about putting, ungloved hands on rashes when you don't know what they are. So, all All right, so his vital signs are fine. He looks really good. His exam otherwise looks fine, except for these legs, which you see. Now, I'll tell you that if you take your gloved hand and push on these lesions, they don't blanch with pressure. And they're not tender. Don't blanch with pressure and not tender. So, what do you think of this rash? What do you think it might be? When I tell you that it doesn't blanch with pressure, that probably speaks to you a little bit. What does that kind of usually mean? A vasculitis. Often this is vascular. This is a vasculitis. So I might go back and ask some more questions. If I'm talking about vasculitis, now when you think about vasculitis and you talk about inflammation of vessels, remember, you're seeing the skin and you see inflammation on the skin, but vessels are everywhere in your body. So go back and ask some questions about other organ systems. Is this person having joint pain? Is there more to the systemic symptoms than this patient's giving you? Maybe you want to ask a little about travel history. Other things, if you live where Peter lives, think about tick bites. Think about exposures like that. Obviously, this could be Rocky Mountain spotted fever, right? Something like a tick bite, but it depends on where you live and what this person does. If they're hiking, and that opens up a whole nother door. But he doesn't have any systemic symptoms. He's no fevers or joint pains, nothing like that. He does have the past history of drug use, so that has to raise a little bit, like when was the last time you were tested for HIV or hepatitis? Hepatitis B and C are associated with a lot of things. Any other complications from his drug use? Think about, when you think about vasculitis, about the urine. Have you seen any blood in your urine? Has your urine been darker recently? Asking questions like that. Any GI issues. So this looks sort of purpuric in some areas. Purpura really is when those sorts of lesions start to coalesce together and get a little bit bigger. So this looks a little purpuric in some areas, but I think vasculitis is a pretty good guess. But that's a pretty broad category. I would describe these as discrete. They are slightly raised, palpable in some areas, pretty deep red. It's bilateral, seems equally distributed. So this is a vasculitis. This particular type of vasculitis is leucoclastic vasculitis. And that's a small vessel vasculitis. And it's a hypersensitivity vasculitis. And it can be basically a reaction to virtually anything. Like a lot of these types of rashes, it could be a lot of things that cause this rash. So the differential could be something like a chronic disease like HIV or Hep C. It could be associated with the medication. This patient has told us they're on some kind of a water pill, so it could be a reaction to that. So in terms of what tests you would get, you'd set, obviously, when you're talking about vasculitis or things that are that look purpuric, you're thinking about platelets. So you're going to send a CBC, of course. I'm curious about the eosinophils, for example. I'd send a regular set of labs. I want to know if I'm thinking about renal involvement or other involvement, what the creatinine is, what the renal function is, maybe a UA to look and see what you see there. Those kind of broad things. There's no specific, in terms of a rheumatologic workup, the question is, do you really need to send all those labs from the ED? And they're really not emergent labs. It may be in your system, your rheumatologist asks you, or some of your consultants ask you to do those things. Know that for leukocytoclastic vasculitis, there is no particular marker that you could send. You might send other markers to rule other things out, but there's no marker that will make this diagnosis for you. So you might send a CBC, metabolic panel, maybe the HIV, the hepatitis stuff, if the patient hasn't been tested or want to do that. Maybe a few room tests, maybe a urine. But if this person looks fine, they can go home. There's really nothing to admit them for here. But if he has organ involvement, like the creatinine's bumped up, that's a person that might need to stay for more intensive immunosuppression. So this is hypersensitivity vasculitis, leukocytoclastic vasculitis, small vessel. It's in that same category as like Wegener's and Churg-Strauss and a lot of those other types of vasculitis, microscopic polyangiitis, that kind of thing. This is capillaries, venules, etc. So this can be from infections, it could be from medications, it can be from a collagen vascular disorder if they have associated lupus or Sjogren's, something like that. They could have something like Crohn's or ulcerative colitis, some kind of inflammatory bowel disease. And there's some malignancies that can be associated with this as well. Hairy cell leukemia is one of them. So this is mostly cutaneous manifestations, but like I said, when you think of vasculitis, think of what you can't see on the outside, so it could affect things on the inside as well, joints and GI tract, kidney. You want to ask about melena, bright red blood, that kind of thing. So a lot of history. When you get into derm stuff like this, you want to ask a lot of questions, send some labs that touch on some other things, think about the multi-organ involvement. You might send some room things like the P-ANCA, C-ANCA, but none of those are going to necessarily make this diagnosis. They might rule some other things out. And then decide on what this follow-up is going to be for this person in terms of your system. There's really no specific therapy for this. Actually, it's just sort of symptomatic. Try to find what's causing it. Maybe if it's a drug, to discontinue that agent. If there's like multi-organ involvement, they might do some steroids or immunosuppression, but you would never start that yourself. In the ED, there's no evidence that starting it sooner is going to make it go away faster, so I would consult a specialist first before I would engage in any therapy. So that's one. When I saw this case, I was like, I don't think I've ever diagnosed leukocytoclastic vacuum. I probably missed this one. So this is good. This is what, coming to these CME courses helps broaden your differential, get some terms that you might not have thought about for a while, and think about those small vessels and arterioles, and maybe that's what's going on here. And it could be a reaction to lots of things. So that's a fun one too. All right, we'll pick up part 2 after the panel, and we'll do some more cases.